Hi everybody, our group presentation will be on barriers and enablers to interprofessional collaboration in Canada. Before we begin, it's important to understand what interprofessional collaboration is. There are so many different definitions of interprofessional collaboration that it's hard to narrow it down to just one definition specifically. On screen is the World Health Organization's definition. Ultimately, interprofessional collaboration is a partnership between healthcare professionals that work collaboratively towards a common purpose. Throughout our presentation, we will discuss both barriers and enablers for each of the following. The first topic we will discuss is relational factors. This section will encompass the importance of relationships between different healthcare professionals. We will then explore the different processual factors involved in interdisciplinary collaboration, specifically looking at the positive influence of information technology on interprofessional collaboration and also the negative effects routines and rituals pose on collaboration. Moving on, we will look at the importance of organizational factors in the collaboration process, investigating which factors enable and hinder successful implementation of care. Lastly, we will distinguish how contextual factors have a major impact on the delivery of care.
Relational issues in interprofessional collaboration are those that influence relationships. Included in this group are factors like power, leadership, hierarchy, socialization, team composition, team roles, and team processes. Any and all of these factors used effectively have the ability to enable team functionality, but used incorrectly, they can become barriers. Since doctors were the first of the healthcare groups to professionalize and generally have the highest number of years spent in schooling and training, they have secured a dominant position when compared to other related professions. Since effective teamwork depends on sharing the power among other team members, this culture of dominance can become a barrier that is difficult to overcome. A recent study found that interactions at medical rounds were often one way from doctors to nurses. When the nurses were asked to comment on why they did not contribute, they said that they found it intimidating because the doctors were moving too fast. The doctors were focused on resolving medical issues so that the patient could be discharged quickly, which often meant that the recommendations of the nurses did not get considered. This one-sided approach can lead to apathy and resistance from team members who feel that their voices are not being heard. For future generations, the key to overcoming barriers created by power inequality will be effective education of students in healthcare fields so that they all recognize the importance of input from each team member. In contrast to the barrier described on the previous slide, a key relational enabler is effective leadership. A high-functioning team will recognize that leadership may need to change as the needs of the patients change. The definition of leadership is changing as interprofessional healthcare teams become more common, and instead of the traditional hierarchical model, newer models are far more democratic and place a large emphasis on leadership attributes and interpersonal skills. A good team leader must possess both professional competency as well as the ability to encourage strong relationships among team members. They must also be able to empower their teammates and maximize the group's potential. Once again, education of new students will play a vital role in training the leaders of the future.
There are 7 processual factors in interprofessional disciplinary organizing. There are time and space, routines, information technology, unpredictability, urgency, complexity, and task shifting. I'm going to be speaking about the barriers and the enablers of processual factors. So let's consider that information technology is an enabler for as a processual factor. What do we do in healthcare that isn't supported by information technology? Not a lot, and we need to understand that the way the healthcare organization is run these days, there are healthcare needs that we can't always meet face to face in group meetings. So it's very important to be able to collaborate through different platforms, being information technology. So what I have done is selected information technology, and we need to remember that we need to continue to work as a team to ensure proper care is delivered. Processual barrier is routines or rituals. So routines can be good as they provide structure. However, it's noted that they can become mundane and then affect group work and patient care outcomes. So as far as interprofessional collaboration is concerned, we need to ensure that we are not doing our group collaboration as day in, day out. Let's meet on Tuesday. And we'll talk about these three things in this order. We need to be able to think outside the box to make sure that we have good collaboration and excellent patient care outcomes. Talking about processual barriers with routines and rituals, let's stop and think about what we do in our everyday life as teamwork. What do we do based on past practice instead of what is evidence-based practice? So are we meeting just for the sake of meeting? In the notebook, Reeves and I'll note 2010. Sometimes when we're meeting for the sake of meeting, we're not using our talents and skills together purposefully. Instead, we're meeting together to just meet for the sake of meeting. So it's a visible demonstration of teamwork rather than actually participating and getting something out of those meetings.
So continuing on now with organizational factors, just by way of definition. So Varani defines organizational supports and organizational factors as follows. Organizational supports and tools that essentially enable the successful implementation and ongoing operation of models of care and effective and efficient interprofessional collaboration. Examples of these supports include a clear business plan, a governance mechanism, workplace policies, and integrated processes. Below is a chart, and I found this very interesting, and I just want to comment on it before we continue any further with some formal discussion in regards to some specific enablers and barriers. So what you see here is a chart of enablers and barriers to interprofessional care. This is produced by McMaster University. It is adapted from a Registered Nurses of Association document on interprofessional teamwork in healthcare. So what I thought was very interesting about this was the number of enablers and barriers that are listed, and we'll speak to that a little bit further. Also interesting to note there is some crossover here between organizational barriers and enablers and so on with some of our other barriers and enablers to interprofessional healthcare, including process and so on. So continuing on with organizational factors, from the aforementioned table, what I was speaking about is that it was sort of interesting to see kind of the vast nature of organizational enablers and barriers. But beyond that, I thought it was interesting to see that some enablers are indeed also barriers. And I've asked you to consider, for example, institutional leadership, which is noted in the chart as an enabler, and then the role of the hospital executive board, which is in and of itself a factor and in fact an example of institutional leadership. So it is cited as a barrier, according to the McMaster RNAO document. So an executive board does make up a large part, of course, of a hospital's institutional leadership. So interesting, and I thought noteworthy to comment on the fact that I think a lot of the question of something being an enabler versus a barrier has to do a lot with the nature of the leadership itself, how supportive they are to the process, and indeed for either assisting or acting as a barrier to providing other elements that would be considered enablers and barriers, such as financial support and so on. So what can be inferred here is that indeed it is the nature of the leadership that makes it either an enabler or a barrier. So continuing on with organizational factors, let's discuss some enablers. The physical space, I thought, was an interesting one. Much is made of the common goal, the suitable process, and so on that we discuss very frequently when we refer to interprofessional teams. But so it's interesting to see that they've commented on, you really need to seem to have some sort of suitable space for this team to collaborate and to flourish. And that's often overlooked, whereas the World Health Organization does exactly list the actual physical infrastructure of what an organization offers as a must for interprofessional collaboration to be effective. So I thought that was rather interesting and noted comment that, in fact, for interprofessional collaborative teams to thrive, they do, in fact, need something as simple as a suitable space to do so. Beyond the suitable space is example that needs to be further supported by the presence of strong administrative support, as well as backing of the institution, which we touched on a little earlier, and that is noted by the World Health Organization as well. So appropriate support frees up our collaborators to focus on care without the added burden of administrative functions. Touching on barriers now, as you can see from the aforementioned chart, barriers are indeed diverse. They contain elements of policy, process, workflow, and even increased responsibility. These types of teams can in fact add to a workday, and often that is seen as a barrier. So Boileau, in her 2011 report, that she entitled Barriers Enablers to Interprofessional Collaboration in Healthcare, cited things as simple as shift changes and staff loading between units, as well as time constraints for patient care as organizational barriers to interprofessional collaboration. So things like frequent changeover of staff can result in miscommunication and, in fact, a lack of attendance to interprofessional collaborative teams. And I thought that was very interesting and very telling, because the best laid intentions can be sort of derailed, so to speak, simply by not having enough hours in the day, floating between units and not being able to provide a consistent level of care, and therefore maybe not having as solid a knowledge base in regards to the client as one would like. Funding is an interesting point to discuss here, simply because it seems that whenever we touch on a healthcare discussion, funding seems to be, I guess a hot topic would be the right word, so to speak. And funding can indeed impact collaboration as a barrier on many levels. So collaboration is impacted when the services recommended cannot be obtained as a result of one's inability to cover costs. And that's a quote from a physiotherapeutic article by Solomon from 2010. So what does that mean? Well, funding is certainly a barrier for a number of reasons. That being said, in this sort of specific example, one of the things that I thought was rather interesting was part of the plan of care may be to include an intervention that is in fact not covered. So say certain physiotherapeutic interventions not covered by OHIP, which may be something that the team arrives upon as an appropriate means of care for the client, but becomes not possible simply because for whatever reason the Ontario Health Insurance, for example, doesn't cover it, and essentially leads the client to have an inability to pay for the intervention.
Contextual factors also include the following: culture, diversity,
gender, political will, and economics. Contextual barriers can also include issues related to social content of work in Canada, such as the impact of gender and cultural based power dynamics that will affect who is able to make decisions and how disagreements will be handled in the workplace. An example of an enabler would be specific relationships and those involved share leadership on a cultural level and have a passion for IPC concept and practice amongst key managers who will act as champions for implementation. The effectiveness of healthcare teams are how well individuals support working in teams by understanding the advantages and disadvantages. The right tools are needed to have an effective team. A successful model of care requires support within the workplace policies with a well thought out business plan and knowledge of the scope of practice they are all trying to achieve.
In conclusion, we can validate that all relational, processual, organizational, and contextual factors play a vital role in interprofessional collaboration. As seen through this presentation, each factor does possess a barrier in some regard to the collaboration process between healthcare professionals, yet they also contain various positive influences as well. It is important to understand when one is a part of a team, the ability to successfully overcome any barrier that may arise during consolidation takes an effort from the whole team, sharing their individual ideas, skills, and knowledge, and attaining a mutual respect for all common goals.